We had some great cardiology cases on my last shift, a lot of great ECG tips. I wanted to share those with everybody out there. Tip number one is about anterior ST elevation MI. We expect to see inferior reciprocal changes, but those can be absent in up to 30% of patients. So if you see those big ST elevations in the anterior leads, don't be worried about the absence of reciprocal changes. That can still be an acute anterior infarction. Tip number two is about hyperacute T waves, which can be very difficult to diagnose. They're often confused with peak T waves, and the morphology features that we are looking for is a straightening of the ST segment before the T wave, a large enough T wave that you can fit the entire preceding QRS complex under it, and we're looking for asymmetric T waves. If you're not quite sure, the best thing you can do is repeat that ECG in 5 to 10 minutes. If these truly are hyperacute T waves, you're gonna see dynamic changes. And then finally, tip number three was about WPW. We know that we should be looking for the delta wave and the short PR interval to make this diagnosis, but that delta wave can be present in some leads and not all leads. So we need to make sure to scour the ECG looking for those delta waves, and that PR shortening really is pathognomonic. So in any patient where you see PR shortening, you should be worried about WPW. Take another look at that ECG looking for other features that would clinch that diagnosis. There you go, 3 ECG tips. Hopefully this is something that you can take to your next shift and improve clinical care.